I'm pleased to be today the master of the ceremony for this second webinar on health financing reforms and policies in India. Let me introduce myself. My name is Aynur Ayıpkhanova. I am a health policy expert from Kazakhstan, and it's my great pleasure to be invited today into this webinar again. After the successful completion of the first webinar of the series on health financing in India, we're happy to welcome you today to the second webinar in the series. The first webinar, titled Health Financing Arrangements for Universal Health Coverage in India, was organized on August 18th of this year and was attended by 93 national and international health financing experts and researchers. The rich discussions by the panelists paved the way to continue our important conversation on this topic of health financing reforms and policies in the current context. Today, our webinar will focus on health financing arrangements during COVID-19 pandemic, and we will explore the health financing choices for reducing catastrophic expenditure during the pandemic. We will also discuss today how best to regain resilience and strengthen our efforts towards UHC. With this background note, I'd like to introduce you Susan Sparks. Susan is a health financing specialist with World Health Organization based in Geneva. She is a health economist with over 15 years of work experience in fiscal policy, health financing, and health systems reforms around the world. In recent years, her work has focused on issues related to political economy of reform and health system efficiency, with a particular focus on Sri Lanka, Ghana, and South Africa. With this rich background, I'm pleased to introduce our keynote speaker, Susan. Susan, the floor is yours, please.
Thank you, Aynur. Well, I'm glad I don't have to introduce myself. Thanks for inviting me to take part in this webinar. So if you could go to the next slide. So my understanding is my job is to set the scene for what will be no doubt a really rich and interesting discussion on the specific health financing response to COVID in India. So I'm going to be giving a global overview of what we're seeing in terms of policy responses, but also the context within which those policy responses are situated. Next slide. So what we know, and again, this is just a graphical representation of what we all feel, is that COVID is not just a health crisis, it's also a clear economic crisis. And I'm glad that we have colleagues here from the World Bank who will also be on the panel, because a lot of what I'll be presenting is joint work that we're doing as part of the upcoming global monitoring report for UHC, as well as the COVID health financing response. So what we know is that there is a large GDP decline in 2020 as a result of COVID, and that many countries actually will see a shrinking of their overall economy if we look at the graph between 2009 and 2020. And so this is really quite a dire macroeconomic situation. So the next slide, please. And so what we know is that this economic decline is really matched by shifts in what we're seeing on the fiscal side. And so the first graph shows the real decline in government revenues. Oh, if you can go back, in government revenues in all income levels, in all country income levels except for high income countries in 2020. And so you have this shrinking of the fiscal revenues that are coming into countries. But at the same time, as shown in the next graph, this huge increase in government outlays and government expenditures in response to the crisis. And what we know is how these expenditures are taking place is in large part as a result of increased deficit spending. And so countries taking on more gross public debt. And so the gross public debt share of GDP increased from 55.3% in 2017-2019 to 75.2% in 2021. And so you have a situation where the overall economic pie is shrinking. You have less revenues coming in. You have more expenditure demands at the same time that you have more pressure for increased debt servicing payments well into the future. So you get the sense of exactly what that fiscal crunch looks like. The next slide, please. What we know is this isn't just a fiscal and economic issue, that households are actually feeling the effect. And so this is data from World Bank mobile phone survey data from 39 low and middle income countries. And so what we see here is that of the respondents of this survey, 70% from lower middle income countries of households actually report a decrease in income during the pandemic, so in 2020, 2021. And that what we know is how countries are, or how households now are coping with this income losses. So first is a reduction in total spending, some of which no doubt relates to health expenditures, but also they're dipping into their emergency savings. And so as countries are becoming more fiscally constrained, you have households that are also more vulnerable overall. Both reducing spending, reduced income, and having to dip into savings and selling assets as well. So after this uplifting setting of the scene and the context, we can go to the next slide. That this really, so what we know here is that this is then impacting on health-seeking behavior. And so this is again from the same survey where 19% of respondents are reporting that they're not able to access the care that they need. And low-income countries, a high proportion, so 65% are reporting financial reasons as the key constraint. What you see in lower middle-income countries is this balance between both financial reasons as well as COVID concerns, and what we know are also supply disruptions that are happening across all countries. So this trickle-down effect is really quite stark and sets the scene for the health financing policy responses. Next slide, please. And so here, what we know is that the health financing responses, and I'm going to really just give a flavor of what some of those are to provoke some thinking and hopefully set the scene for the future discussions from the panel. They take place across the health financing functions, but also importantly, these take place within the overall health system context. And so there's this question of how aligned are the financing responses with what we know needs to happen on the service delivery shifts, the health workforce, the supply chains, the governance systems. And then also, I think we have this big question mark of, we know that what I'll be able to talk about are descriptions on what the health financing policy response is, but there still is a question of what this impact is ultimately going to be on universal health coverage. We have some clear hypotheses through different pathways, but ultimately these shifts need to impact on ultimate outcomes. Next slide, please. So through a few examples of what countries have done. And this is again in direct response to COVID. And so this is an example from Ghana where, so Ghana went into the pandemic with, they had a decrease in the domestic public share on spending on health as a share of GDP, and a decreased prioritization of health within the overall government budget. And so in some respects, the pandemic, the government has used this as an opportunity to increase general government revenues with a notional earmark for the health sector. And so Ghana has had a lot of experience in these earmarks, which has not shown to actually provide additional revenues for the health sector due to fungibility concerns. But they actually have increased the national health insurance levy as well as the VAT flat rate by 1 percentage point. And so now it's a question mark of, so we see this policy shift, but one is how will these additional revenues be allocated? How sustainable is this source? So if the reason to introduce this was motivated by COVID and is literally called the COVID-19 health levy, what happens into the future with those increases? And then this question of actual additionality for the health sector. Next slide, please. So the second example, and so this is taken from work that the George Institute has done for the WHO Sero region. But what we know is across all regions, many countries have introduced policies to make COVID-19 related testing and treatment either free of charge or to have low fixed rates, user fee rates. And what we know is that these policies have shifted over time as the pandemic has progressed. And so in Sri Lanka and Indonesia, initially tests were free for symptomatic and contacts, and then they've gradually been expanded, whereas in Nepal and Bangladesh, they've actually introduced user fees related to COVID-19 tests, both in relation to a concern about potential overuse, but also related to fiscal concerns. And so I think there's a big question mark of what the actual impact of these policies are going to be. And we know from previous experiences that a lot of these free care policies or user fee removal policies, they need to be matched with public revenue, additional health financing mechanisms and responses in order for these services to actually be free at the point of use for the user. And so this is just to say that we're going to need to be monitoring the impact of these actual policies on financial protection as we move forward. So the next slide, please. So the third example is from colleagues in the World Bank related to policy and budget adjustments related to COVID-19 in Laos. And so here what we know, and I'll speak to a bit more, is that a lot of the health financing related changes have related to public financial management system shifts. And so the need for additional flexibility and the need to rapidly disperse and distribute funds across the sector. And so there's the revenue part, which is clearly important in relation to that increase in expenditure that's needed, but also thinking through, okay, where do those revenues actually sit within the budget? What are the mechanisms to release those emergency funds to the front line? And in the case of Laos, they actually had to shift the budget approval and disbursements from the Ministry of Finance to the Ministry of Health to allow for quicker disbursements. And this all needs to be matched with legal and regulatory shifts as well. And so it's really this coordinated response. And still, even despite many of these shifts, we know that the budget execution remains a challenge and actually getting those funds to the front line. And so there still is a lot of need to monitor how these additional funds that have been mobilized have actually gotten to their intended use going forward. The next slide, please. So this is an example from Argentina, and so I won't talk through the details of this, but I think it's particularly relevant for India because Argentina is also a federal system which is highly decentralized. And so what Argentina did was that they used an existing scheme, so the Programa Sumar. So it was an existing coverage scheme with an explicit benefit package that was based on a formula of conditional grants from the federal to the provincial level. And so what they did was at the federal level, they expanded the covered population to initially include anyone over 65 years of age. And so the way these conditional grants work in Argentina is that it's a capitation rate. So the federal government gives a per capita amount to the province level for each enrollee. And so they immediately increase that capitation rate. And so that's important because obviously it increases revenues, but it also uses an existing financial transfer mechanism. But then these expansions on the revenue and the population side at the province level, there was this expansion of the benefit package for COVID-19, but also an increase by 300% of the actual fee for service. So the payments to providers related to these services. And so it really was this coordinated response in thinking through what are the incentives throughout the system and how can this existing mechanism and really that strategic purchasing lever be activated in response to COVID. So the next slide, please. So we also know, as I mentioned, that public financial management shifts have really been central to the response to COVID. And some of these, and we want to stress here that this is about both flexibility in spending modalities, an issue that was persistent in the health sector before COVID, this issue of how to ensure both flexibility related to the need for funds to be able to match sometimes uncertain needs, but with strong accountability mechanisms. And so what you've seen in terms of experiences is this fast track of spending authorization, direct budget transfers to subnational levels, so building from both the Laos and Argentina examples as well. These advanced payments to providers, so how do we front load the payments instead of paying providers retrospectively? And then simplified procurement. And so this is an example from India that on how the strict public procurement procedures have been really alleviated to enable the fast procurement process. So the next slide, please. So some of the key emerging messages is that we know that the health financing response must go well beyond revenues to consider all the financing functions. And then this coordination across mechanisms and the use of conditional grant mechanisms, because on the public health side, much of this question of how to mobilize a subnational response based on often national level priorities, and sometimes global even. And then to leverage and activate existing financing mechanisms. And then this importance of matching flexibility with accountability, which goes hand in hand with the need to monitor, track, and evaluate. These policies have been put into place, but we really need to understand their impact. But importantly, this is about informing future policies as well. And so what I've described are kind of emergency reactions and responses, but there's really a question of how can we move from this kind of cycle of emergency response to one in which we actually rebalance priorities, that there's investments in what we call common goods for health. And so the surveillance systems, the information systems, the laboratories, which really serve as the foundation for both UHC and health security, but also are really important functions to be activated in the case of an emergency. So the last slide, and this was developed along with P4H, as well as the World Bank and GFF. I don't know if I can switch, but we've developed a guidance related to COVID-19, the COVID-19 related health response, health financing response, as well, but I just want to stress, I don't know if the next slide can be moved or, there it is, okay. But I want to stress that the common themes that we put that have come out in terms of health financing for COVID-19, these are not distinct only to COVID-19, that these really cut across, because what we know is it's one budget, and so it's one dialogue and one approach. And so some of the common themes are flexible, timely, and accountable PFM systems, this efficiency in targeting, which is particularly critical given the macro fiscal context, and then shifts in provider payments to facilitate service delivery. And we know that cash transfers also, where it's unable to make services free of charge, is this question of how to reduce financial barriers with cash transfers. And then this need to really introduce and to track these expenditures, which will be particularly challenging given what we know has happened in terms of household surveys and the ability to collect data given the nature of the pandemic. So hopefully I've kind of provoked some ideas and some thinking, and I really look forward to hearing the details from the panel in terms of what's happening in India and some of the priorities there. Thanks so much.
Thank you so much, Susan. This was a very interesting, very thought-provoking presentation. I think WHO giving such umbrella background that's applicable to many regions of the world is really beneficial to us here at this panel, at this webinar. Now I'd like to transition all of us to the next stage or step in our today's webinar. I'd like to invite here Tushar Mokashi. He's our moderator for today's panel discussion. Tushar is our senior technical specialist with Access Health International. He has more than 8 years of experience in health accounts, public health expenditure analysis, strategic purchasing, and public-private partnership, costing of health services, and universal health coverage. We have had a privilege of having Tushar Mokashi at the first webinar. It was a blast. His moderation really helped to spur lively discussions among panelists and interactions with the participants. So now I'm very pleased to give Tushar the floor. Tushar, the floor is yours, please.
Thanks, Aino. Thanks for the introduction. I hope I'm audible. A very good afternoon to the panelists and participants joining from different parts of India, and a very good evening and good morning to all those who are joining from other parts of the world. To begin with, I would like to thank the organizers for giving me this opportunity to moderate this important discussion today. And thanks, Suzanne, for setting up the stage. Before I begin, I would like to first give some housekeeping instructions, which will be helpful for all of us to go through this discussion smoothly. So we have 5 panelists today on the panel, and each of the panelists will speak for 8 minutes. we will have back-to-back 5 presentations, and we will then open it up for question and answers. We will also request the audience to please put their questions and questions in the Q&A box. Try to avoid the chat box so that the panelists can see the questions right away. And please don't forget to write who the question is addressed to and your name as well if you want to. I would then now want to move towards our main discussion. I'm sure that everyone sitting in the audience today has very closely seen the devastating effect of COVID-19, be it the health condition of family, friends, colleagues, be it their health expenditures, or be it their household incomes. And we know, as a matter of fact, that the pandemic has forced millions into poverty and has increased inequality to a larger extent. We also know, which is the good news, that economies are now recovering. But we know for a matter of fact that there are still large disparities in the country while we are fighting to build back better. We know it very well that the COVID-19 is not going anywhere. It is still there, it is going to be around, and there will be new variants which will keep the health system on its toes. Therefore, I believe we as researchers and practitioners community should help the system best prepare for the future. We should monitor and evaluate what has worked and what has not during the response phase, and share this knowledge with policymakers domestically and internationally. Therefore, in today's panel discussion, we will focus on the impact of COVID-19 and its implication on the health financing in India. How has the health system responded to the pandemic? What are the notable examples of health systems initiatives in India and abroad that made considerable differences in the COVID-19 response? What are the learnings for the future? And with this background, I would now take you through the flow of these panel presentations. We will first hear from Meeta Chaudhary, who will initiate the discussion highlighting the macroeconomic impact of COVID-19 on the fiscal space for health. Then we'll hear from Nishant Jain, who will highlight the role of one of the world's largest government financed health insurance scheme, PMJY, in India's fight against COVID-19. Then we'll hear from Grace Cavania, who will discuss the national and subnational resource mobilization and strategic purchasing for COVID-19 response. Then we'll hear from Owen Smith, who will talk about the role of external funding and its utilization for COVID response. And then we'll hear from Rahul Reddy, who will discuss the regional responses from Southeast Asia region. Without any further delay, I would like to hand it over to Meeta, who is an associate professor at the National Institute of Public Finance and Policy and has done some notable work on health financing in India. Over to you, Meeta.
Thank you, Tushar. Good afternoon, everyone. Okay, so I think Susan has given an excellent overview of the fiscal crunch globally, and India is obviously no exception. Can we just go on to the first slide? The next slide, yes. So India is no exception, and the 15th Finance Commission in the country has actually referred to this fiscal crunch as the Caesar effect of the pandemic on state finances, which is nothing but basically what Susan explained, that due to the economic slowdown induced by the pandemic, there has been a significant compression of revenues of the general government, both the states and the union government together, which in turn has really, compressed the fiscal space available for public spending in general, including health. So on one hand, we have a revenue compression. On the other hand, we have the need for increasing, or there's a pressure to increase public spending, increasing public spending not only for health, But we also need increased public spending for social security and other sectors which are required to counter the adversities of the pandemic. So the state finances, when I say state, it includes both the state governments and the union government in India. The state finances have been really cut through two pressures. One, the shrinking revenues. On the other hand, the pressures to increase public spending. Now, I think this revenue expenditure gap has been even more it's been compounded by the fact that there are also borrowing constraints and fiscal rules of the government at the subnational level, which restrict the quantum of borrowing by states. So, if you have a revenue compression, one could borrow and, increase public spending. However, because there are certain government rules, the fiscal rules, particularly the FRBM Act, which restricts public spending, we have a situation where there is a significant fiscal crunch and there's a dual pressure of countering the negative shock on the revenues and increasing public spending. So can we get on to the next slide? Yeah, so if you look at the emerging evidence on this effect, now what has actually happened, that's again, you see in many parts of the world again, in the pandemic year, if you compare it with the pre-pandemic year, which was 1920, you see that gross tax revenues of the union government declined, had a negative growth rate, -5%. Total receipts of the state government, which is its own revenues, including the central transfers, again had a negative growth rate. So both the union government and the state government, there was a negative growth of revenues, which means revenues are actually compressed at both levels of government. Interestingly, however, in the pandemic year, if you see, expenditures did not have a negative growth. Despite the negative shock to revenues, expenditure growth was not negative. At the state level, there was a 5% increase in public spending, which means that states had actually borrowed to counter the negative shock on revenues and try and maintain some growth rate in public spending as a whole. So, and it's important at the state level because states are the primary entities for health spending in India. So at the state level, you see that despite the fall in revenues, states have borrowed funds to keep public spending levels at least 5% growth rate. I think here I would also like to mention that you see due to the difference in the distribution of powers between the union government and the central government, bulk of the revenues in India, and as in most parts of the world, are actually collected by the union government. And states which have a lower level of health spending, most of the poorer states with relatively poor health achievements and relatively low levels of public spending are the ones which are precisely dependent on the union government for transfer of revenue. So whenever there's a lower collection at the level of the union government, that really is passed on to states through a lower intergovernmental transfers, through a lower tax devolution in particular, and which really adversely affects particularly those states where health spending is low, the relatively poorer states, and states where we do not want the health spending to go down any further. So the positive message is, despite a revenue crunch, we have had some positive expenditure at the state level. Next slide, please. Yes. And within the expenditure, if you see, what has actually happened? Interestingly, of course, it was the pandemic year, and we did expect that there will be a tilt towards the social sector. You do see, one can see that actually the growth in expenditure in social services was much higher than the growth in expenditure on economic services. If you compare 2019, the pre-pandemic year and the pandemic year, the social service growth rate was 6%. The growth rate in public spending on social services was 6%, whereas the growth rate in economic services was just 3.5%. So states did prioritize social sector spending in the pandemic year. And more importantly, within the social sector, if you see, it's still the final figures are not yet out. But if you look at the preliminary figures on spending by 15 major states, you see the health spending actually increased by 16% in the pandemic year. Okay? Now, it's expected that it was because of the pandemic, you would have a higher priority on health expenditure in that year. But remember, this has come at a cost in the sense that, there have been very little growth on education spending, nutrition spending, etc. So I don't know how far you can really see this playing out a similar pattern over a number of years, because this may not be sustainable in the short to medium run in terms of a very high growth in health expenditure and negligible growth in a lot of other important sectors. But the positive note here is that we do see a priority towards social services spending and a priority on health spending in the pandemic year. Now, of course, state-wise, if you see the figures, there are some states like Tamil Nadu where you had a 40% growth rate of expenditures in the pandemic year, and even states like Chhattisgarh, Orissa, etc., had a more than 20% growth rate of health expenditures in that year. Now, is this sustainable? Now, this was the pandemic year. The question is, would we see a priority or an increased health spending in the short to medium run? Will this pattern continue is something which we don't know. And we also would like to see where these health expenditures is actually going, because as of now, we still do not have the information on where exactly detailed expenditure on each state or where have the expenditures been increased, so that once we know where are we spending, we'll know how this spending is going to play out in the short run. Next slide, please. Yes, I just have 1 minute, so quickly finding over. So in the short run, I really do not see the possibility of a very significant increase in the fiscal space for health spending. We have seen some recovery, but we do not expect it to we are still below the pre-pandemic levels, and some of the other factors which are going to come in next year, for example, the withdrawal of the GST compensation to states may impose further constraints at the state level for public spending as well as health spending in particular. Now, what are the available? Now, giving these constraints, what are the available handles which we have? Now, I think the health grant from the 15th Finance Commission really has come as a breather. However, this needs to be spent through local bodies, and we know the challenges that are faced in spending through the local bodies. So that's something which we really need to ensure that we utilize completely. We can also have unused funds which are lying in the bank accounts of implementing agencies, and many states have already started, initiated these steps. And lastly, as Susan stressed upon again, improving public financial management, I think this is the most important step. There are a whole lot of amateur reforms that can be done in this stage. And I think I've already crossed my time. So I will just end here saying that I think we need really a very, very targeted focus on public financial management. Thank you, Tushar. Over to you.
Thanks a lot, Meeta, and I'm sorry to interrupt you in between through the chat. But I think keeping the time is also important. I know it is an important topic, and we will have opportunity to discuss when the questions come up. So thanks for this excellent and informative presentation, Meeta. 2 points that I gather from your presentation and would like to also highlight are that in future, pledging more resources for health is going to be very difficult for governments. And therefore, managing the available resources efficiently will be even more crucial. In this scenario, I believe prepayment mechanisms are something that will be a very important device to provide a safety net to the people, and that is where the next presentation, and it gives me an opportunity to call upon Nishant Jain to please come and talk about PMJY's importance and the role it played in India's fight against COVID-19. Nishant Jain, as we all know, is heading the Indian portfolio of health and social security for German Development Cooperation Agency and is the Senior Advisor to National Health Authority and Ministry of Health and Family Welfare. Over to you, sir.
Thanks, Tushar. Thank you a lot. And thanks to the previous speakers, Susan and Meeta, for setting up the stage very nicely. So I can save some time on my initial slide. If you can go to the next slide, please. Yeah, so this is already covered. Just 2 points I wanted to make here, that the pandemic has effect on everybody, but for it has a bigger impact on many vulnerable groups like women, for example, like elderly. So there's much more impact on them. And we need to see that how do we mitigate that. But also, when I see from a different angle, there is some silver lining, because now health is being talked about a lot, which is something which was not very common in India and many other places. So this is something that a lot of attention is going to help. People are realizing that it's an investment, it's not an expenditure. And a lot of augmentation of health infrastructure has happened that can actually help for the future also, because it's not that this infrastructure will be gone waste. So it can be used for many other things, like we have a new oxygen plants and all these things which are being prepared can be used for future. And it can be a catalyst for big reforms in health. Across the world, we have seen a lot of big reforms have happened in health after big crisis. So this is something I think would be very useful. Next slide, please. Now, this also many of you are aware, but just for some people who are not too much aware. So, in India, when we got independence in 1947, the model was adopted, which was to strengthen the public health infrastructure. And basically, all the money from the government went into setting up sub-centers at the village level to big hospitals at the national level, and in between the continuum of care was there. So the idea was that we set up these hospitals, they will provide everything for free and things will be fine. But somehow it didn't happen. And private sector started playing bigger and bigger role. And in fact, now almost 3/4 of the primary care and almost 2/3 of the inpatient care is being provided by the private sector in India. And of course, at the same time, still we have high out-of-pocket expenditure, almost 60%. And access to healthcare is also limited, especially for the vulnerable population. So in the past, I will say around 15 years or so, Government of India and state government thought about doing some demand side financing, where they talked about starting health insurance or health assurance schemes. And the main idea was that these schemes will improve access to healthcare and reduce catastrophic health expenditure. Now, mind you, that these schemes do not cover primary healthcare, none of these schemes. So, and a big expenditure from out of pocket is on primary healthcare related to medicine and all. That is not covered, that government wants to cover through a different route, where they have started something which is called Health and Wellness Center. 150,000 government is planning to set up in the country. And that's where they will provide comprehensive primary care. But the other part of that reform is setting up National Health Insurance Scheme, which I will talk about now. Next slide, please. So in 2018, Government of India launched this new scheme called Pradhan Mantri Jan Arogya Yojana. Is basically a health insurance scheme covering bottom 40% of the population, which is roughly 500 million population. Now, I have written here 650 million because many states have expanded the scheme further. And now we are covering almost 650 million people under the scheme. And this provides an inpatient cover of roughly 500,000 Indian rupees, which is something very important because it's a cover which can take care of almost any inpatient condition for almost, I will say 99% of the inpatient conditions. And then there is no cap on family size and age. And in terms of number, this is the largest health insurance scheme in the world. And it is portable across the country. So that is something which is very unique. You can go across the country and get a paperless and cashless service. Next slide, please. And in 3 years of the implementation, the scheme has finished 3 years very recently. And we have issued almost 170 million Ayushman cards to the beneficiaries. And almost $4 billion worth of claims have been made in the hospitals. And almost more than 26,000 hospitals are empaneled under the scheme, where 48% are private. And even in the portability also, we have almost 0.3 million cases of portability has happened, where people have gone outside their own state to take the treatment. So scheme has a good start. Of course, it's a long way to go. Next slide. Now, this is something which the main topic for today was that, what was the response from PMJ and the National Health Authority in terms of COVID? Now, something many times, people criticize India that many times we take things in a more reactive mode. But in this time, people were very proactive. NHA was very proactive from the beginning. The moment the pandemic started and things started showing the numbers, we worked on starting new packages. So many new packages were added. The most interesting one was that in PMJ, generally it's an inpatient scheme. So we don't have testing as a separate package included in the scheme. It is part of the treatment. But for the first time, we added separate testing packages for the COVID-19 as a standalone package. And because we are allowing that, we also allowed standalone labs to be impaneled for the first time under the scheme. And the IT system was quickly revised to make it happen. Now, also for a treatment, a lot of things were required. So what was done, that new packages for COVID-19 treatment were designed and added. So what was done in PMJ, that we have a list of things which are covered at the national level. There is a list, and then a state can modify it. So in the national list itself, a lot of packages were added. Many other packages were identified which could be used for treatment of COVID-19. They were also marked there. And then these new packages also took care of the cost of, let's suppose, mask and the PPE kits and all these kind of things. And states also had the flexibility to add packages, and many of the states added these new packages, and they were also approved and integrated into the IT system. We also impaneled new hospital. So this has helped basically in expanding the treatment base. So what was happening? The government anyway made that treatment and testing for COVID will be free in all the public hospitals. That was anyway done. But then we also saw that there was a huge rush and load on these public hospitals. So PMJ certainly helped in expanding the treatment base, where more hospitals were able to provide the treatment. People could go to the private hospital also and get free treatment under the scheme. And more than almost $500 million worth of treatment was done under COVID in PMJ. It could have been much, much more, but since public hospitals were doing it free of cost anyway for everybody, and they didn't book these treatment on the scheme. So that is why this number in the public hospital especially was underrepresented, because they got separate budget and they were treating public and putting things into the IT system and all. There was no time because of a huge rush. So that's how it happened. Next slide, please. Now, it's not that only new packages and treatment were done. Some more things were done which were also very critical. Because what happened, that we also saw that there were new complications arising like black fungus and all these things. And for that, new packages were prepared at the later half of the pandemic, especially during the second wave. So that is something which was very important. Also, what we realized that a lot of non-COVID related conditions were not getting treated under the scheme because either lockdown or people are avoiding going to the hospital or for many other reasons. So what was done, that we tracked patients who needed regular care like dialysis or chemotherapy and all. And we saw that whether that was being done or not for those people and for those conditions in different districts. And then we also tried to contact these people to see that what was happening and is there any problem. We also try to analyze the data to see if there is a sudden drop in some procedure or some geographical areas in terms of utilization of services, so that appropriate corrective action can be taken. Also, empanelment of new hospital, as I said, was done. Tracking of SARI and ILI packages were also done, and information was shared with Ministry of Health so that they can take appropriate action. We also did a lot of support in terms of telecalling and call center, which helped Government of India and Ministry of Health in combating the pandemic further. Next slide, please. Now, this is something which is expected. So we saw this utilization trend quarter-wise for PMJ. And we see that in the first wave, during the first wave, there was a huge dip. And in the second wave, again, there was a huge dip. So this was Q2 2020 and Q2 2021. But the promising thing is that Q3, the numbers have increased much more than before COVID numbers. So which means that a lot of pent-up demand which was there is now being fulfilled, and people have started coming back for the treatment, which many of them were avoiding earlier. Next slide, please. So now what is we are doing? So data, we have a lot of data, and data is being analyzed continuously to identify patterns and changes in utilization from before and after, not after exactly, but now we are closely monitoring the districts with significant drop, specialties with significant drops or changes what was happening. A system has been put in place to design new packages, and constant monitoring and revision of pricing is being put in place. We are also trying to move towards more sophisticated way of provider payment mechanism like DRG, and that is being explored, that how we can move towards that. Primary care plays a very critical role. We have seen across the world that countries with stronger primary care have focused and have tackled pandemic much better. So we are trying to now create a continuum of care approach between health and wellness centers and PMJ, so that the same person can be tracked across the continuum of care, and that will certainly be quite useful. And very recently, many of you may have heard, government has launched Ayushman Bharat digital mission, which is creating a digital backbone for the country, digital health backbone for the country. And that is something, again, which is PMJ is integrating with that. And that will be very useful for, for prevention, for seeing things, for catching things very early. And these are the things which we are working on. And of course, we'll be happy to share more later during question and answers. I'll close here. Thank you very much. Back to you, Prashant.
Thank you, Nishant, for being right on time and great insights and great information. I think what is important here to note is that during this crisis situation also, the PMJY quickly reacted, created new packages and added them to the benefit package. This is very clearly, it highlights the need for a robust and strategic purchasing mechanism. And that is where I would like to call upon Grace from WHO to speak about the strategic purchasing and resource mobilization at national and subnational levels. Grace is the Technical Officer, Health Financing for UHCA and Health at the World Health Organization Country Office for India. Over to you, Grace.
Thank you so much, Tushar. Thank you, Nishant, Mita, and Susan for setting the stage. I'll be reflecting on some of the policy levers, the domestic policy levers that were used to finance the response. And I'm going to take a functional approach to this. Maybe have the next slide. So I'll reflect briefly on the domestic resource mobilization at the national and state level. I'll look at the role of PFM in this. I'll touch very briefly on the pooling of resources and what that meant for efficient spending. I'll look at the purchasing options for COVID-19, and this will be largely within the general budget revenue, so outside of the health insurance arena. And with that, I'll be focusing largely on the engagement of the private sector. As Nishant said earlier, this accounts for about more than 60% of service delivery. And so it's a very critical stakeholder. And so what was the role of the private sector in the response, both for the first and second wave? I'll look briefly at the vaccine financing issues in India and what comes out of those. And then maybe have a bit of reflections that we can build on within the Q&A session, but I'm also hoping Rahul can reflect on a little later. Next slide. So on the DRM side, for both the first and the second wave, India being a decentralized country, both the union and the state level had to play a role within the corporate federalism framework. And we see that both union and state budgets had a role to play, especially in the beginning of the response. The union budget, which had just been read during that time, at least for the first wave, played a big role with money coming from the Ministry of Home Affairs, but also from the Ministry of Health and Family Welfare, the disaster response funds, as well as the disaster preparedness and response fund there with 103 crores. Also, we had a bit of money coming in for the local governments in some of the 14 states from the post-devolution revenue deficit grant, which is something that the 15th Finance Commission had proposed. PMJ, we've seen its role. At the state level and at the union level, we had some supplementary funding coming in, announced by the Prime Minister for the emergency healthcare package, and states had to provide co-financing for that. We also saw many relief funds or chief minister's funds. At the union level, we had the PM Cares funds, which were funds that were mobilized from the citizenry, both within the country, but also from the diaspora, which also provided some support. So for instance, the PM Cares Fund provided funding for ventilators. In the second wave, it has contributed to vaccine funding. Some states have contingency funds like Bihar, which doubled the size of its corpus in order to cater for funding, as well as Odisha, which boosted its size by about 200%. So these were some of the resources that came in from the public side. Next slide. What was the role of public finance management? We know that public finance management systems are supposed to help us in terms of efficient expenditure, allocation of funding, disbursement, spending, and monitoring of public funds. And so there were some changes that came through, both on the policy side and the process side. On the policy side, we saw some austerity measures, both at the union and state level. So things like wage cuts, payroll deferrals, freezing of allowances like the DIA, mess allowance, increasing in borrowing for states that was granted by the central level for states, so from 3% to 5%. Budgetary allocations to contingency funds, but also decreased spending on capital intense programs across the board. On the process side, we saw some changes around delegation of financial powers, so decentralization of financial powers to lower levels with enhanced spending autonomy, and there was an enabling legal framework for that. We saw relaxation of the procurement laws and internal controls. So for instance, some states permitted ministries of health to departments of health, sorry, to advance 100% payment to providers, which wouldn't have happened before, waiving of stamp guarantees from providers, for instance, but also increasing the autonomy of some of the procurement officers. Reallocation of budgets from some programs to emergency programs. So we saw some relaxation of the environment rules. Some MDOs were allowed to use their savings without prior approval for the Ministry of Finance to enable faster disbursement. Next slide. So on the domestic front, another source of spending, unfortunately for India, as Nishant alluded to earlier, is out-of-pocket spending. And we saw an increase of this, in some cases leading to medical debt and impoverishment, at least from anecdotal evidence. As Susan has alluded to earlier, we have currently no way of tracking resources within the COVID timeframe to be able to say for sure what that looks like, at least for instance, in India, but at least from anecdote, we can see that there was increased spending out of pocket because of high costs of treatment. In some cases within the private sector, a day's treatment would account for about 1.3 million rupees. We also saw increased hospital stay that contribute to that because of severe disease, increasing need for home care with concentrators, oxygen concentrators needed, nursing care that put pressure on families, increasing out-of-pocket payments, even for the insured. And so in some cases, some voluntary health insurance schemes came up with special top-up packages to cater for that. And so this is something that I think we need to reflect on as a global community in health financing, and how we demonstrate what the effect of the pandemic was in terms of financial protection and impoverishment, because I think it has policy issues. Next slide. On the pooling side, again, as we've said, India is a decentralized context. The issue here that I want to highlight is there are multiple pools that came into play. So you have funds from the National Health Mission at the central level going down to the state level, funds from the state treasury. You have the disaster relief funds all converging at the Ministry of Health. You also have the state relief funds in some cases that we are buying equipment, we are purchasing vaccines, some of things that we are being paid for by the State Department of Health. And so where is the coordination on that? That is something that I think going forward, the government has to think about a framework for greater coordination of spending across levels, but also across funds. Next slide. Like I said, with the purchasing arrangements, really the issue here is on how you engage the private sector. Because within the National Health Mission framework, for instance, the general budget revenue, public health hospitals use line item budgets, which is what obtained during the pandemic. Some states like Telangana tried to be a bit more innovative in that space by providing bonus payments to health workers. But when it came to engaging the private sector at state level, there was no pre-existing framework that states could fall back on. So there was need for one innovation, but also cross-learning across states. So some states, there was some variation in some of the in the practices. On the provider payment side, many states used fee-for-service payments for testing, which in some cases the prices were fixed a bit later for some states. There were per diem payments that Odisha used for recurrent costs, but also used monthly rental payments for fixed costs around infrastructure that hospital needed to put in place. For instance, West Bengal used capped fee-for-service payments, but in all these cases, the providers had complete autonomy. On the price setting side, some were early adopters in terms of let's fix the prices in order to protect the consumer. Others like Maharashtra, Karnataka, did that later on in response to public pressure because of the financial barriers that were being set. So there are some lessons there. But again, the mechanisms of price setting varied. Assam used PMJ rates to benchmark in order to set prices for their non-COVID packages, because that's what they contracted the private providers to provide services for. In Odisha, there were bilateral negotiations. So the state negotiated with each private provider separately. In Karnataka, we saw a bit of collective bargaining. In West Bengal, we saw a bit, and Maharashtra, the government just fixed the prices without consultation. Next slide. With different effects there, which we can explore later. On the vaccine financing side, as we know, this has been a big issue for India. It's a huge vaccine drive. Now we're at almost 100 crore vaccinated. But we've seen at least 3 different policy shifts across the time horizon. So it was launched on the 16th of January, initially with the government taking on a smaller target group of frontline workers, people aged 45 years with comorbidities, and a government union budget set aside with that. And like I said, some philanthropic resources coming in. But then it went on to about 4 months later to liberalize, bringing in the states as well and the private hospitals with a bit of implications for equity there. And because of the equity implications, then the government again now has centralized the financing and is providing at least up to 50,000, it is reported, crore for vaccine financing, which shows that there is a greater role for public financing for vaccines. So I'll just go to my last slide to Sham. I think in reflecting, and we can build on these ones later on in the Q&A session, the issue is we do need predominantly domestic, and that is public financing. But again, from Mita's presentation, at least for India, that does not bode very well for us. So what does that mean if we want to address out of pocket for India on the UHC and health security side? I think the issue, like Mita and Susan highlighted earlier, PFM laws and strategic purchasing will be very critical. And for India, in the strategic purchasing sense, that will mean developing a framework for engagement for the private sector in that kind of space. Vaccine financing requires predominantly public spending for equity. And that is, I think, a lesson that lower income countries need to take away from the Indian experience. And lastly, we need to take on board some of the guidance on financing for health security around the common goods for health. And we can build on this later on, especially things around strengthening surveillance, laboratory, networks like Susan talked about earlier, because this was an issue that also emerged during the Indian experience, and we can build on that later. Thank you very much, Tusha.
Thanks a lot, Grace, for touching upon several crucial points, of which I would like to pick one point, which I would like to also link to the next presentation, is about the surge in external funding during the pandemic, be it for vaccines, equipment, or infrastructure strengthening. With this, I would like to hand it over to Owen Smith, who will shed more light on the external funding part. And Owen is a senior economist working with the Health, Nutrition and Population Global Practice of the World Bank, currently based in New Delhi. Over to you, Owen.
Thank you, Tusha, and thank you very much to the organizers for inviting me. And good afternoon to everyone listening in. So as Tusha said, I'll speak about external financing for health during COVID-19. Next slide, please. In the few minutes I have, I'll try to touch on two issues. First, quite broadly, the global trends on fiscal stimulus packages and the role that external assistance is playing within those packages. And secondly, I'll just conclude with a few numbers and a glance at the external support provided to India in the context of COVID-19. And just to say, I think the headline message here is that India, as a lower middle income country, the role of external assistance for health is relatively small. It's not a game changer. It's not zero, but it's not a huge amount. And that's consistent with what we see generally in lower middle income countries when it comes to external financing for health. And next slide, please. So this map shows the size of fiscal stimulus packages that have been rolled out around the world. This is IMF data. You see the green, whether it's light green or dark green, these are countries that put at least 5, if not 10% of GDP into their fiscal stimulus packages. You see this was the norm in Latin America, Eastern Europe, Western Europe, and North America, whereas in Africa, Middle East, and Asia, generally the size of these packages was less than 5%, reflecting that they have lower tax revenues in general, less capacity to borrow funds. So wide variation in the fiscal responses around the world. Next slide. So within these fiscal stimulus packages, health has been a relatively small part of these packages. This is drawn from a recent ODI study, which I would recommend anyone who wants to look it up. It's very informative. You see, I'll draw your attention to the right-hand side. You see the relative size of the fiscal stimulus packages, almost 25% of GDP in high-income countries, more like 5 or 6% of GDP in low-income countries. Within packages, it's a relatively small piece of the pie. It's much more money is going into liquidity support for the financial sector, private sector, and also non-health spending, social assistance, welfare programs, and so forth. So health is a smallish piece of the puzzle. Next, please. When you look at those fiscal stimulus packages and how they've been financed, for the most part, it is domestic financing that countries are relying on. In this graph, you see the dark blue is the change in fiscal deficits from 2019 to 2020. The light blue or gray is the domestic financing, which you see is much larger for the high-income countries, but also for middle-income countries. And then the smaller bars, which are orange or red, I don't know, on my screen, the legend is not visible. I don't know if others can. I think the slide is shifted down, but there is a legend there. And the orange or red is the multilateral and IMF lending. So IMF, I believe, is the the dark orange, the multilateral development banks is the lighter color, and the red is some debt forgiveness. So generally speaking, the public sector international assistance is a smaller part of how fiscal stimulus packages have been financed compared to domestic resources. And next, please. Looking more narrowly at multilateral development banks and their financial flows, you see the main multilaterals there and the increase in their financial flows from 2019 to 2020. The World Bank's two lending arms, IBRD and IDA, which is the concessional window, pretty large increases in 2020, similarly with the Asian Development Bank as well. So from the 2019 base, fairly large increases. Next slide, please. We're now looking more specifically at health and the external assistance coming to health. The World Bank in April and May of 2020 had prepared emergency COVID support projects in over 100 countries. All told, in the last 18 months, I think there's now over 150 new COVID operations in about 108 countries. Other multilateral development banks have similarly expanded their engagement in health sectors to support the health response. The vaccine financing, which we heard a little bit about already, 30 billion support has been offered by MDBs, 20 billion from the World Bank, 9 from ADB. But the utilization of the resources made available is relatively low, and that's because of the vaccine shortages that we're all acutely aware of globally. So the World Bank has pledged 20 billion, but so far about 5 billion has been projectized in about 50 countries. And then the COVAX facility, which is part of the ACT accelerator, the WHO is leading with others. It was designed to ensure equitable access and to aggregate demand for lower prices. So I think that the concept was a good one to share vaccines equally around the world and to get lower prices. It has gotten off to a rather slow start, particularly because high-income countries bought up the vaccine stocks, of course, so they didn't exactly play fair. And then an over-reliance on the Serum Institute of India as one of the biggest manufacturers of vaccines globally. So for India, having the domestic capacity made a big difference. For other countries, that was an important barrier. Next slide. So a few numbers from India. 2.5 billion was the external assistance going to the Ministry of Health and Family Welfare for the COVID-19 emergency response. You see the breakdown across ADB, AIIB, the World Bank, and JICA. All of this came through in April, May, September of last year. Just to qualify these numbers, there's been additional support beyond this from a number of the lenders for non-COVID specific, so broader health system strengthening. That's not counted in the 2.5 billion. They have additional support provided to other non-health sectors is not included here. There's been some ability to reallocate funds from existing projects on the ground. And just to put this number in context, 2.5 billion did not all go through in FY21. Most of it did, but not all of it, I believe. So this is around, I think, in the range of 12,000 to 15,000 crore in FY21. This is roughly in the same ballpark as the overall Government of India COVID health emergency response to the Ministry of Health and Family Welfare. I'm not counting vaccines here. That's about a 15% increase of the revised budget. But that's only 5%. This 2.5 billion is only about 5% of government spending on health in India once you include states as well as the Government of India. So as I said right at the outset, external financing for health is not zero. It can provide a useful shot in the arm, but it's no pun intended, but it's not it's not a huge game changer either. And of course, India with its domestic vaccine production is in a better position than other countries. Next slide. So my last slide, a few of the key considerations, and some of these have already been alluded to by the earlier panelists. Does external financing actually reach the Ministry of Health? This is always a question, or does it get fully taken by the Ministry of Finance and Treasury? I think in India's case, it generally has gone through to the Ministry of Health. How much of it gets down to the state level, or is it largely used by Government of India through their own sort of spending areas like ICMR and CDC, etc. The modality of lending makes a big difference for flexibility of the funding. If there's the funding can come as an advance, so it just comes immediately, or it's done on a reimbursement basis for actual expenditures, which makes it less flexible and I think therefore less helpful to the government. And of course, aid is fungible, so funding to other sectors can also benefit the health sector. So I've done a whirlwind tour of that topic. I hope it provided some insights, and happy to have some discussions. Back to you, Tushar. Thanks.
Thanks a lot, Owen, for a thought-provoking presentation. I would now like to call upon Rahul Reddy to share country experiences in responding to COVID-19 pandemic from Southeast Asia, and also tell us what we can learn from those countries. Rahul is the national coordinator at Health Systems Transformation Platform. He's a health systems and financing expert and was instrumental in revitalizing health accounts in India. He focuses on health financing research and policy for universal health coverage. Over to you, Rahul.
Thank you, Tushar. A very good afternoon, and thank you everyone for joining today. Thank you all the experts. They presented the key scenarios we faced and what lies in future. I'm happy to share my learnings from country experiences in India. I think this would be of a great learning to India as we go into taking long-term measures to fight such health emergencies and also strengthen the health system, mostly the financing arrangements, which are currently quite fragmented and unresponsive to timely building up of emergency response in India. We all recognize that health financing arrangements deployed in any country are determined by the socioeconomic and political context. The next slide, please. And are largely based on the existing service delivery, financial and administrative systems that have evolved over the years. COVID-19 was an unprecedented and unique situation where the response time was short and it was coupled with an economic crisis. Understanding the gravity of the situation, it is fortunate to see how countries responded. They amended or established new arrangements within existing limitations, which is commendable to a large extent across the world, and especially the low and middle income countries in Asia. We also notice there were similarities in countries' general line of response. And these enabled financing arrangements to work according to their intended best. I know a lot would depend on the country context and people may differ in terms of experience, but overall, I think what we see is a good enabled system so that for financing and health systems arrangements to work at this short notice. Some of these common enablers are governments providing stimulus packages to address economic crisis and ensure delivery of essentials during the lockdowns. Governments also mobilized domestic and external funds and reallocated existing funds for emergency response. They enacted or amended laws to allow flexible spending at the provincial or local level. COVID-related health services were all included in benefit packages if there were insurance programs or social health insurance and social security measures, or they were specified and widely publicized in where they can be taken and how they can be utilized. In countries with high private sector dependency, especially in South Asia and also India being one of the examples, we observe progressive engagement with private sector, though not very participatory. we do see price caps and other regulatory measures that were taken to curtail out-of-pocket expenditures to an extent. And in countries with government health insurance programs or social health insurance, purchasers allowed flexible use of funds. And they negotiated for new technology, drugs, and vaccines so that they're all available to a large extent of the population, mostly the vulnerable and poor groups funded by budgets, where middle and higher income groups would have to spend on their own from their out-of-pocket expenditures or through their private insurances. Saying that, let us look at some of the examples from individual countries. Next slide, please. When we study the financing arrangements of each country in depth, I came across 6 country examples that were noteworthy. Each of these countries implemented the common enablers that we just discussed. I will highlight only the financing arrangements to be aware of the possibilities that exist before us. Only time will tell if these had any impact or how effective they were. But in the interest of time, I'll be very brief because we have to cover about 6 countries. And I hope the basic financing mechanisms are aware to most of the attendees. So Thailand, which is a natural comparator for India, also with along BRICS countries for all UHC related discussions, it was able to immediate response through its existing government and social health insurance schemes, which almost cover 99% of the population. The processes were well defined in these schemes and they were standardized, so all population groups could receive health services required, and equity was maintained. Insurance coverage without any contributions was extended for a long period of time, 6 months to 1 year at least. Those households which were uncovered by any insurance due to their unemployment or low income status were covered through universal coverage scheme, which was directly financed by government budgets. Hospitals were ensured timely payments, and same reimbursement rates were fixed for both public and private providers to ensure quality of treatment. Wherever there were any co-payments at the time of service delivery, these were abolished, and these were factored into the reimbursement rates for both the public and private sector hospitals. Other country which did very well is Japan. Japan's system is again based on their national and social health insurance. And there also exists a long-term care plan for those above 70. All these 3 schemes work in a very decentralized setup. So the local needs and local contexts are always taken into consideration. To respond quickly and to avoid a lot of discussion and consultation at various levels, government created a fund here where new and reallocated budgets were pooled. It is called as the Emergency Subsidy Fund. From these pooled funds, budgets were allocated to the prefecture and local governments based on criteria set up around the number of COVID patients and the severity of response required. This fund ensured to cover hospital reimbursements, incentives or rewards to health workforce, and also to pay for new technology and drugs that were required by hospitals and health facilities across the country. Co-payments for those covered by insurance and long-term were continued. Some local governments even set up deductibles for high-income groups. All out-of-pocket payments by low-income and vulnerable groups were compensated by public funds, and this allowed for a cross-subsidy between the rich and poor during the pandemic time. South Korea is essentially a social health insurance-based system, and the same channel was used to fund COVID services and hospital reimbursements. Here, co-payments were abolished, and the equivalent amount was reimbursed to hospitals from government budgets directly, so that people do not have to suffer at the time of taking services, and they can access any health facility during the crisis. An interesting arrangement we see in Korea is the lost income of medical institutions, pharmacies, and allied organizations was also compensated by government budgets. This we don't usually see in other countries. This was to alleviate them from the usual revenues that they would receive when they could take up elective procedures. And because of COVID procedures, they were not able to take up those kind of cases. So the compensations were estimated and based on monthly wages. Next slide. In Indonesia, like Japan, finances were pooled through a special fund. It was called as the PEN program, and channeled through the existing universal coverage program, which covers almost the entire island nation. Hospitals were reimbursed through differential per diem rates. So the differential was based on service delivery criteria and the setting, if they were urban, rural, an island nation, or what services they were covering for COVID. The government also engaged with the private sector employers to fund the vaccination program for their employees and dependents, which really brought a good, healthy participation from the private sector in terms of delivery of vaccines quickly across the country. Philippines used their existing health insurance program, PhilHealth, to channel the reallocated and the new funds that were available. External funding again played a lot of role in Philippines. Hospitals were reimbursed through case-based payments, and these were again, midway shifted to global budgets with certain bundled payments. These were estimated based on the average value of past claims in the last month or 90 days, which was very quick, though may not be efficient in the long run, but it was the need of the hour. Advanced payments were made to hospitals, and accreditation period for all health facilities was automatically extended. This eased a lot of administrative engagements between the purchaser and the hospitals, so that there was no grief in trying to serve patients. Then China, a very populous country and again a comparator as BRICS to India, it already implements a well-defined and decentralized insurance program, which covers almost 95% of the population. Health insurance contributions were waived from the households, and these were compensated to the government entities at local and state levels by the government budgets from the center. And out-of-pocket payments for services for those who were not covered in insurance were paid by public medical assistance funds. These also covered those services that were not covered by insurance, and these were directly reimbursed to the households. When we see all these 6 countries, we see a theme run across. The focus of the interventions was to ensure that people can access services that they require without any barriers, or at least with minimal barriers. And they do not pay out-of-pocket contributions because they are already in a deprived condition. Government budgets are the main source of financing during this crisis, and also they will continue to remain because they also reach a lot of primary care and remote facilities across these countries. And to mount a quick response, they used existing standard insurance and universal coverage programs that they already have to channelize funds. This brings an administrative ease when the defined service is available, and it is easy to communicate across the country, and also allows for hospital negotiations for better price setting or payment schedules, which can all be streamlined for a quicker response. So what do we learn from these 6 examples for India is the national and state governments did mount an immediate response, definitely. And however, this had its limitations, like we have seen from Grace and other presentations. Given the enormity of financial and human resources mobilized and the complexity in reaching vast geography and population, we have done well, but it had its limitations. From our own experience, the media howl that you see in India and the emerging research that is coming out, we understand that there was severe distress due to service delivery deficiencies. and out-of-pocket payments across middle and low-income groups. Like these countries, our interventions could have been more focused on no out-of-pocket payments, at least for the near poor and poor, so that financial barriers for access could have been removed. And direct and timely reimbursements from budgets to both public and private hospitals or labs and pharmacies could have really helped. That said, this requires us to work on the long-term measures, because currently we have a very fragmented financing system in India, which is quite complex, and it would be better to have a single authorized entity to anchor specific response in consultation with the states and the local needs. Most importantly, to fulfill the fiscal space required, when we all know from Meeta's presentation that future is a little bleak than what we ought to believe, we should reassess the capacities of the national state relief funds to mobilize finances for health emergencies. And also in general, because most of these relief funds are used for paying for social health insurance programs and ad hoc payments to hospital care and stuff like that. So we need to really reassess how these funds could be built. And we should get some stringent lawmaking for earmarking funds from budgets and also non-government sources, especially to maintain a surplus, so that we would be better prepared for future emergencies.
Rahul, I think in the interest of time, I'll have to stop you here.
Yes, I'm done.
Yeah, that's fantastic. Thanks for a very interesting, important presentation. You have put across several points that are pertinent to the current situation, and we have seen a lot of learning from different countries. And now I think with whatever time we have left, I think we can move on quickly to the question and answer. I think we can answer 3 questions, and I would request Nishant to address one. And I'm really thankful to all the panelists who have already answered quite a few questions in the Q&A. Nishant, please.
Thank you, Tushar, and thank you to all the people who asked few questions. So one question which was very interesting, that what is being done in terms of provider payment and also for the fraud control. So basically under PMJ, we have a system which is called package rate. It's like a fixed amount which is paid to the hospital for a particular treatment. So it's like, you can say, it's a cruder version of DRG, not as sensitive and sophisticated. So now we are working towards and exploring that if we can move towards DRG, but of course it's not a very simple process. You need certain amount of data, certain amount of costing systems. So we are working towards it, and hopefully we will move towards more sophisticated provider payment mechanisms. And in fraud control also on the PMJ, now we have a big team which works on not only preventing fraud, but also trying to identify frauds through based on different IT tools, including artificial intelligence, machine learning, etc. And we quickly identify these triggers and potential frauds. And then once they are confirmed, there's a strong action which is being taken against the hospital. And many hospitals have been even removed from the scheme when they were caught doing fraud. And a lot of money potential, I think few hundred crores have been saved for the government by these measures. So I'll stop here. Thank you, Tushar.
Thanks, Nishant. Meeta, do you want to take one question?
Okay, I see 2 questions which I can sort of very briefly answer. The first question was on, we talk of utilization when we talk of improving public financial management. So the question was, what are the major reasons for poor utilization? Now, we have done a study of NHM. We know that about more than 40% of the NHM funds remained unutilized, okay, in the last couple of years. So we tried to look into the reasons as to what actually leads to poor utilization. Very shortly, I think there are major fund flow issues there in terms of how the administrative procedure, there are complex administrative procedures involved in the release of funds, which leads to delays in release of funds, partly because the financial architecture of NHM is also extremely sort of, it's a very complicated architecture, or in some sense, it is also a little rigid architecture that really creates hurdles in the, we need a lot more flexibility in terms of utilization, to increase the utilization, particularly when it comes to NHM. Do we have time? Do I just very briefly talk about the other?
Yeah, please do. Okay. We'll take 2-3 minutes of additional time. Yeah.
Okay, so the other question was on what are the alternative ways of raising and pooling funds for health? Okay, this is a question which we have been grappling for decades now as to, we depend on this 1% of GDP. How do we gather more funds for the health sector? No, I think Susan also very mentioned, very importantly in our own presentation also, one of the instruments we often talk about is earmark funds. The earmark funds, or you have assessed, a particular a tool to generate funds for the health sector. But if you look at the experience across the countries, this doesn't form a major source in any of the countries. The primary base has to come from the what tax financing, and even if wherever you have these earmark instruments, as Susan mentions, one, there are issues of fungibility, because you don't know, even if you collect the funds, there are ways in which these are fungible. Secondly, also these earmark taxes often may not be sustainable over time. So there are issues with, I would think there are, at the margin, I think all of these are important. Every bit of it, adds to the overall kitty, but the chunk still, I think, has to come from major tax base. I think I would.
Right. Yeah, I fully agree with you, Meeta. Grace, do you want to take one for answering one question, or?
I saw a question on data from on funding and resource mobilization efforts from local self-governments. The data I have is very patchy across different states, and it differs with different by source within different states. So I think I don't have a comprehensive data set, but I think based on Meeta's presentation, she may have a little bit more from some states, and she can speak to that. Yeah.
Right.
We don't have information on local bodies yet, the revenue mobilization. Yeah.
Right. I think we do not have much time now left to answer any more questions, but we will definitely respond to all the questions through email, and we'll personally send all the emails. And I would like to sum it up very quickly, because there's no more time left with us. That, as I said, that we are in resource crunch, and we have always been in a resource crunch, and now even more, given the double burden that we have right now. And the only thing that I have always felt, and I have always conveyed, is that what we can do with the available resources and how can we use them more efficiently is what is always there in our hands, and we should focus more on that. Is where I would want to close this. There are many things that I really wanted to say, but since there is no time, I would like to close by thanking all the panelists and give it to Ainur for a word of thanks. Thank you, Ainur, and thank you all.
It is my pleasure to wrap up our second webinar devoted to discussing health financing in India in the times of COVID. This was really a rich discussion, and I hope it was a great learning experience for all of us. We heard about pressures experienced by governments and households alike and their effects on health-seeking behavior across the globe from Susan. It was really refreshing to learn about different countries' experiences and strategies and solutions. I also just wanted to kind of briefly thank each and every panelist. The way we learned about so-called scissors effect of the pandemic on health spending from Meeta. Nishant exposed us to government finance health insurance schemes, which is another big chapter in our today's discussion. Grace has presented us various aspects of domestic resource mobilization in India and pooling arrangements and many other approaches and solutions which shed light to the vast experience of India in addressing these challenges. Owen, on his part, has introduced us to some global trends on fiscal stimulus packages and the role of external funding during COVID-19. And he also capitalized on India's experience and health response to COVID-19. And finally, our panelist speaker, Rahul, has discussed health financing arrangements with us from a few countries, but capitalized again on India's vast experience. So I think this discussion really has been rich in content, but we are always constrained in time. So as a master of ceremony, I'd like to thank Susan from WHO for her opening presentation, keynote address, the panelists, our moderator Tushar for making this discussion lively and interesting and smooth. I'd like to send my special thanks to P4H network, to WHO controls in India, to Access Health International, and all other partners who made this event as an interesting discussion today, who made this webinar possible. Before we close, I would like to remind to all participants that this webinar has been recorded. The recording will be available on YouTube channel of P4H account, and your participation and feedback is welcome to help us improve our series of webinars, which will follow. You will also receive some feedback forms to share your reaction with today's event, and we're looking forward to hear from you.